So thanks, Charlie and Meredith, for everything you do for us and creating this wonderful opportunity. Welcome everyone to what should be a very interesting discussion today, how evolutionary behavioral sciences can help us understand behavior in a pandemic. So when the pandemic began, I thought our contribution as evolutionists would be mainly looking at the evolution of virulence. Not so. It turns out that behavior turns out to be far more important. And we have 3 of the world's experts today to give a joint presentation summarizing the latest work in that area. And it's also wonderful to highlight UCL. I got to know Ruth Mace there in 2002 when I did a sabbatical there. She and a number of other wonderful people were doing evolutionary medicine. We thought about starting an evolutionary medicine program there, but London is so expensive, there's no way we were going to get people from all over the world to join us. But Ruth is carrying on the charge and doing a wonderful job of creating new scholars and scientists who are developing these ideas. She was educated at Westminster School, then took her bachelor's degree and her PhD in biology at Oxford. After appointments at Imperial College and the University of East Anglia, she moved in 1991 to UCL, where she became professor of anthropology in 2004. She's a fellow of the British Academy and a past president of the European Human Behavior and Evolution Association. She's joined today by Emily Emmott, who took her degrees at UCL, where she's now a lecturer in the Department of Anthropology. She's a human behavioral ecologist who studies how environment influences human development and behavior. In particular, her focus is on institutional child rearing systems and their implications for health and well-being. She's extending crucial work there on cooperative child rearing. And finally, Deniz Salali is a British Academy Research Fellow and lecturer in anthropology at University College London. She took her bachelor's degree in molecular biology and genetics in the Technical University in Istanbul, Turkey, then a joint master's degree in Groningen, the Netherlands, University of Montpellier, and University of British Columbia. She's now at UCL with the gang, and her fieldwork has been in the Congo rainforest, studying hunter-gatherers and the influence of culture and evolution on behavior and health. With that, Ruth, take it away, please.
Thank you very much. Okay, so, right. Let me just share. Okay, so what we're going to do today is, when the pandemic struck, one of the things that our group decided to do is we were, well, obviously we were all in shock to start with, and then we thought we needed a group project, even though we were all at home in lockdown. But we also realized we were hearing a lot from epidemiologists and various other scientists, not surprisingly, and public health people. But we thought that we did have something to say as evolutionary behavioral scientists. So we put together a publication which came out in Evolutionary Medicine and Public Health. And what I'm going to do today is just briefly summarize some of the points that we made and then go on. That's going to be about 10 minutes. And then I'm going to move on to work that 2 of the authors on this paper have done since we wrote this paper. And so then you'll have 10 minutes from Emily and 10 minutes from Deniz, just about, and then hopefully we'll have time for discussion. Okay, so how does evolutionary behavioral sciences help us understand behavior in a pandemic? Well, this is not rocket science to those of you that have studied evolution and behavior. So evolutionary models emphasize costs and benefits to individuals or their immediate kin. And, you know, that sounds pretty obvious. So consequences of that are, first of all, individuals rarely do things for the good of the group unless there are some kind of advantages, and those are normally reputational advantages, and then they might start cooperating. That's one of the key things. And, you know, you might think, well, obviously anything to do with a pandemic, governments are interested in the public good, and anything to do with the public good is therefore going to be an incredible challenge, because that is not how we're necessarily wired up. And the other insight that we stress in this paper is that costs and benefits differ for everybody in the population. So if you are young or old, male or female, from different ethnic groups, if you're rich and poor, there might be all sorts of differences in the costs and benefits that are influencing you, and therefore your optimal life history strategy, or indeed your optimal strategy in any aspect of your behavior or your attitude to risk, might be different. And these are the things that we felt needed to be emphasized. So just to kind of talk about costs and benefits. So I just want to give one example of something that has happened. When we wrote this paper, the vaccination program was at its very early stages, and there wasn't the big vaccine rollout that there's obviously been since then in the Western world. And so we focused quite a lot on social distancing, as that was more or less the only sort of main mechanism that was being used at the time. But we also did think a little bit about vaccination. And I do clearly remember the narrative at the time was very much, oh, well, you know, we mustn't really force anyone who's hesitant. We've just got to persuade them that this is the right thing to do, and try and get everybody on side, get everybody vaccinated. And since then, just to go back to the sort of cost benefit framework, I think President Macron of France was having a big problem with vaccine hesitancy, and he just got straight fed up with it. And he said, right, if you want to go to the pub, if you want to go to a restaurant, if you want to go into any public building, you need a pass sanitaire and you need to be vaccinated. And the response to that was nearly 1 million people in France made a vaccine appointment on a single day after he announced that. So I think that the cost benefit framework of sort of, if you like, a kind of behavioral ecology perspective, you've got to like change the costs and benefits, and then you're going to change behavior. And I think that's the kind of overarching thing that is, it's extremely simple, but it was surprisingly little featured in some of the discussions that were going on at the time. Okay, so in our paper, as I say, I'm only going to do a quick brief introduction, and then I'm going to hand over to my co-authors. But in this paper, which some of you may have had a chance to read, we actually focus on certain areas to do with trying to keep COVID-19 under control. So we looked at compliance with regulations, we looked at social distancing, domestic violence, the success of contact tracing, misinformation, conspiracy theories, vaccine uptake, and international cooperation. And these are all areas, as I say, that we reviewed in the paper. And I'll just talk about some of the key points very quickly before I hand over. So, I mean, compliance and social distancing, well, I've already mentioned to you the fact that costs and benefits are very different for different individuals. And one of the things that was quite clear was that humans, you know, we evolve as social beings. You can't have a policy. One of the first things our Prime Minister said when he finally got it was that, you know, stay at home, don't meet anyone. That's a great way of stopping transmission of a virus, but it's impossible. We're social beings. You can't do that for anything other than a very short space of time. And some of the key points, children clearly need socialization. They need education, which I have to say was horribly neglected here in the UK. Sexual behavior was effectively illegal for people living alone for an extremely long period of time. Young people were unable to make their social networks. And as all evolutionary anthropologists here know, child rearing is not just the responsibility of a mother, but a whole kin group. And Emily's going to talk about that more in her talk. So social distancing policies, you know, if they don't recognize this, then people are going to break the rules. And that's exactly what everybody did. Nobody could follow, you know, the people that were experiencing these costs could not keep with the rules. And everyone was breaking it. I mean, actually in Britain, it was quite weakly enforced, but the, you know, as I said, reputation was really the only enforcement mechanism, which was quite strong to start with. But politicians and epidemiologists were tracked by the media, and many of them lost their jobs as a result because they broke the social distancing rules. And it was actually very interesting that the reasons they broke the rules were always either they were visiting their parents, or they were visiting or being visited by their lovers. And it was absolutely completely predictable. And in the end, they had to change the rules so that you could make social, obviously that undermined the whole public health message if key important people were found to be breaking the rules, so they had to change the rules. so that social bubbles could, take this into account. We have a section on domestic violence. Again, I think probably an evolutionary view of domestic violence is developing, whereby domestic violence is seen as a way that partners terrify women so that they don't leave relationships that they would like to leave, essentially. And obviously during lockdown, the bargaining powers become, routes of escape become more difficult. Social support is more difficult to get. Unemployment, poverty, for example, obviously risk factors in that they motivate women to leave relationships. And it's when women try and leave relationships that they are most at risk. And so domestic violence did get a lot worse. So that was a significant public health side effect of the disease. I'm not going to talk about conspiracy theories because, the sort of cultural traditions and cultural transmission aspects, Denise is going to talk about in her section, but we obviously the cultural evolution side of it is obviously very important as well, which we'll address this a bit later on. And then international cooperation. So cooperation, I already mentioned, there's literally millions of papers, I would imagine by now, certainly hundreds of thousands, but possibly millions, written on the evolution of cooperation. And that it is hard to generate, but it can be stabilized in certain circumstances. And international cooperation, in other words, cooperation between groups, is probably even more difficult to stabilize than is individual cooperation. So, that maybe we shouldn't be too surprised that that's going to be a hard one. And anything that is some of these models do illustrate that anything that's generating conflict within society, like elections, trade wars, whatever, is going to make large-scale cooperation at national or international level more difficult to achieve. And, certainly we've seen, we very quickly saw the rise of vaccine nationalism. And here in Europe, we were already having a fight about Brexit, and that quickly turned into a fight about who was going to have whose vaccines here, there, and everywhere. And I'm not even sure that's been entirely resolved. And also low levels of international donation. So really most countries who've got plenty of vaccines have shown themselves more willing to give a third dose to their citizens before giving a first dose to citizens of other countries. So perhaps again, not too surprising from an evolutionary perspective. But we conclude the paper with sort of three sort of overwhelming sort of summarized points, really. And we could have made others. It's certainly not an exclusive list of things, but obviously, as I just said, good of the group arguments don't go too far. Individuals are willing to pay the costs for the good of society, but if it involves a long-term cost to the individual, then that is not sustainable unless it's balanced by some other motivation. And those motivations, either individual or family-based incentives or reputation costs. The thing about reputation costs is they normally operate very locally. So if your local context is anti-vaccine or anti-social distancing, then reputational costs are not going to work at all. Heterogeneity, as I said, was the other big point we want to make in all these cases. Costs and benefits depend on ecological context. So similar policies can meet with different reactions because the costs and benefits are different, and therefore people in different socio-demographic groups are going to have a different attitude to taking the risk of infection. And so, for example, if you're male, if you're poor, if you have young children, there's quite a lot of data now showing you're less likely to comply with various rules to do with minimizing the spread of COVID, and lower socioeconomic position, not being represented by your leaders, obvious pathways to wealth and status not clear, mean that you have to prioritize other behaviors that don't necessarily protect you from COVID. And, it's quite possible that this so for example, structural racism is an obvious one, in that when the racial differences in infection rate first came through, a lot of people were interested in biological differences. But obviously, you know, behavioral differences or interaction of social, economic, biological factors could easily derive some of these patterns. And it may even be that, you know, as we found, you know, with some other kinds of medicines, you know, some sort of disinterest in vaccine in some parts of the world might be that there's simply so many other, so much larger mortality risks that it's really not even reached their radar in some parts. So a behavioral ecological perspective highlights that behavior change is much more likely to emerge from environmental change rather than just telling people how to behave. So obviously health information is super useful if you don't know the risks, but the reason you're not adopting something might not be because you don't know the risk. It's more likely to be that you do know the risk, but the cost benefit situation for you is not the same as it is for others. And therefore, for some groups, it just doesn't make sense to follow those recommendations. And the difficulty of that kind of message is that improving prospects for individuals to change their behavior is about probably as much about changing their socioeconomic and physical environment. And this is obviously a much more challenging and costly for governments than just issuing advice. So, I mean, we found that with, for example, advice on teenage pregnancies. We found it for advice on HIV, you know, a sort of an assumption that it's a lack of knowledge that is causing phenomena that governments don't like is often not the case. It's not a lack of knowledge. It's just a different set of costs and benefits. And unfortunately, or fortunately, depending on the way you want to look at it, obviously, it's going to be much more difficult to improve people's environment, to improve their prospects, and all these things that are likely to shift the costs and benefits in favor of more long-term strategies, or strategies that you know, have the luxury of avoiding some of these sort of high-risk behaviors. So I think behavioral ecology thinking implies that there are rather few shortcuts to successful mitigation strategies. Okay, my 10 minutes is up. I'm going to stop there. Thank you. I'll pass over on to Emily.
Right, thanks, Ruth. Hopefully you guys can see my screen, and if not, I'll just, there you go, fab. Thanks everyone, thanks for having us here today. What I want to do is just very quickly talk through a project that by accident emerged during COVID. So we were just about to go into the field to collect social network data with mums with babies in London. Lockdown struck in the UK, so we kind of pivoted to looking at social networks during lockdown and how that's associated with postnatal depressive symptoms among mums with babies in London. So there you go. Given the international audience, I just thought to explain what exactly happened in London. So London was the epicenter of the epidemic in the UK, and essentially we were advised to stop non-essential contact and travel on the 16th of March 2020, and lockdown measures legally came into force on the 26th of March 2020. And with this lockdown measure, we weren't allowed to do anything, so we were required to stay at home unless exercising, shopping for food, or seeking medical attention. All non-essential businesses were closed, and this included childcare facilities and schools. Public gatherings of more than 2 people were banned, and in addition to national, hang on a second, sorry, I'm going a bit quick. In addition to national measures, there were also local measures at local authority level, for example, by closing public toilets, closing car parks, and so on. So people were really stopped from going anywhere. These measures remained in full force for almost 3 months, which is quite a long time, and there was essentially limited between household contact permitted. And the really key thing, at least what we're interested in, is that childcare and schools only remained open for essential workers and vulnerable children, and childcare bubbles were not permitted. So there was this artificial severing of any sort of support during the lockdown. Oops, sorry, something wrong with the screen. Great. Okay, I don't know if you can see the blue lines. I don't know how to get rid of myself. So with lockdown 1, there were severe restrictions of access to allo mothers beyond the nuclear family. And our questions were really, what happened to maternal social contacts in this novel pandemic environment? So we were interested in egocentric social networks. And also we were interested in how this impacts maternal mental health. And we focused on postnatal depression, so depression that tends to be associated with, oh, sorry, I don't know why it keeps on moving back and forth the screen. Anyway, postnatal depression measured through the Edinburgh Postnatal Depression Scale. Right, so in terms of methods, we took an exploratory approach because it's this kind of novel environment. We kind of wanted to keep it open without restricting it to specific hypotheses. And we were also restricted to a self-completed online survey. So we advertised through social media, and people were eligible to take part if they gave birth in London, England, with a child aged 6 months or under at the time of the survey. I just wonder if someone might be accidentally drawing on the screen.
Yeah, sorry, I can't figure out how to turn off the annotation function, but so people can stop clicking on the screen until I can work that out. And Emily, maybe if you stop screen sharing and then reshare, it should remove those annotations. Sorry about that.
Let me see if I can share it a different way, and that might.
I think just resharing it the same way should work.
Okay.
Yeah, it should clear out the previous annotations. Sorry, I can't quite figure out how to stop that from being allowed. But
okay, there you go. All right, so in terms of our data collection, women could self-report up to 25 important people in their lives. And also we asked about the Edinburgh Postnatal Depression Scale, which is a validated depression measure. There you go. So I won't talk too much about the demographics of the sample, but one thing I wanted to flag is that with any opportunistic online social media sample, we had a relatively affluent and privileged population, which is really important to think about, I guess, in terms of the limitation, because obviously cost and benefits vary between socioeconomic groups, but also the risk of postnatal depression is much higher amongst, we know, of more disadvantaged groups. So what we found is that overall, women reported around 11 to 12 people in their social networks, of which around 4.6 or 5 people were family members. And they on average reported around 2 mummy friends. So mummy friends we defined as non-kin who had children under the age of 18 months. So there might be some sort of kind of support system going on there. We found that remote communication was relatively high. So they were communicating all across their social networks, but actually compliance to social distancing measures were quite high, at least in the first lockdown, where most women, most women saw around 4 people in person. So that includes their partner, so their whoever they're cohabiting with. They saw on average 1 other kin member than their partner. So their in-person social network was really, really reduced. In terms of the Edinburgh Postnatal Depression Scale, we saw a massive rise amongst our sample, which we weren't really expecting to this degree. So normally when you see a distribution of EPDS, we see it very skewed, but as you can see on the screen, it was normally distributed. So that's a substantial increase in EPDS scores amongst this sample. And the mean score for our sample was around 10. And this is substantially higher than previous pre-pandemic estimate of 6.4. And actually around 50%, so 47.5% of mothers in our sample met the criteria for postnatal depression if they score over 11. So our question really was, how do these network characteristics associate with EPDS scores? Unsurprisingly, we found that the greater levels of communication and in-person connections with the social networks was associated with lower EPDS scores. So what this suggests is that social distancing measures that were implemented by government may have had, of course we don't know the causality, but may have had have led to an increase in postnatal depression amongst mums, which is not particularly surprising. What was also unexpected and interesting is that the maintenance of contact with kin, so this isn't to do with the social network size per se, but the composition of the social network. So the more maintenance with kin, the higher the EPDS score. So this was kind of opposite to what we were kind of expecting, but we took that as perhaps kin members taking the risk, I suppose, of COVID infection or potential other costs of kind of breaking social distancing rules, although we don't know for sure, to provide extra support to mums who had higher depression scores because they were particularly in need. So there's this kind of greater benefit, I suppose, of allomaternal support for mums who are in need. So we also conducted some qualitative analysis of open text data with 122 mums. And I thought that was really interesting in that it kind of gave us some background information behind the mechanisms that might be going on, behind the associations that we were seeing. So first of all, it wasn't all negative. Mums reported enhanced bonding with baby within the nuclear family due to lockdowns, because that kind of protected mums from unwanted disturbances, I guess. You know, they could say no to people coming round, but actually there were lots and lots of costs that mothers reported. So there was the burden of constant mothering because there was zero support with household tasks, looking after baby. So this was associated with feelings of exhaustion and guilt, which overlaps also with depression symptoms. Despite the fact that virtual contact was associated with lower depression scores, actually lots of mums reported that this type of support was inadequate, and they found it really difficult to get information around childcare and how to look after their baby, so it led to low maternal confidence. And finally, mums really talked about lost opportunities, the inability to expand their social networks, and how this might have affected their baby's development due to the lack of physical contact with others. So just the take-home message here is that lockdown 1 severed alloparental support for families with infants at a time when we know that they really need extra support. And unsurprisingly, it seems that, I'm just going to go back the slide, it seems that there's significant high costs associated with these types of social distancing measures, with potential implications for long-term maternal and child health, because we know that depression symptoms have long-term consequences. Treatment for postnatal depression is relatively ineffective. So the take-home point really is to minimise potential harm of social distancing measures. Policymakers should not assume that nuclear families are actually able to look after children on their own. And these types of more relaxed, not necessarily relaxed, but policies that took into account that families need support were then introduced in the further lockdowns that happened in the UK. So that's it from me, and apologies for the random slide movements, and I will pass on to Denise.
Thanks, Emily. That was great.
Thanks, Emily. So I'm going to share my screen. I do that. Does it work?
That's great.
Okay, great. So hi, everyone. I'm Deniz, and today I'm going to be talking about the vaccine hesitancy project that I've been running since last year. So what vaccine hesitancy refers to a delay in refusal or acceptance of vaccines, and it's been on the rise, especially in some countries across the world. And that's why in 2019, WHO listed vaccine hesitancy as one of the top 10 threats to global health. And as I said, there is cross-cultural variation, so we don't see the same levels of hesitancy in every country. And I was wondering why the people in some countries are more hesitant about vaccinations than others. So I want to first talk briefly how I decided to run this project. In May 2020, my collaborator Mete Sefa Uysal and I, we were running a separate project looking at behavioral responses to the pandemic in Turkey and in the UK. And as part of the project, we also asked participants online. So there were more than 4,000 people both in the UK and Turkey. We asked them their willingness to get vaccinated against COVID-19 if there was a vaccine available, because at that time there wasn't any vaccine yet. And we found that people in Turkey were much more hesitant about getting vaccinated against COVID-19. There were around 30% of people who said they were unsure, whereas in the UK, this was around 14%. And when we looked at the predictors, we found that the strongest predictor controlling for many demographic factors were people's belief in the origin of the virus. So what you see in this plot is that people, if they believed in the artificial origin, so for example, if they thought that the virus was man-made, SARS-CoV-2, then their vaccine acceptance rates were much lower compared to people who believed in the natural origin of the virus. So then we wanted to investigate this further and wanted to ask questions. First, why there is that variation across cultures on vaccine acceptance rates, and then what are the predictors of this vaccine hesitancy, and also like general trust in vaccines, and how can we tackle vaccine hesitancy. And we were lucky to get some funding from UCL, and with that we first did another survey, this time including participants from the US in March 2021. And we also did interviews with 40 participants in Turkey who are hesitant about vaccinations. More information you can find on this project and some blog posts in our website. And here I'm going to be only briefly talking about the survey results. Okay. So first, we have looked at the predictors of vaccine hesitancy across different cultures, and you can see the summary of our results in this preprint as well. so as I said, from the 3 countries, we had demographically representative samples. And then we looked at different vaccination attitudes. So one attitude was, one measure that we looked at was general vaccine trust. The other was general vaccine hesitancy. So we measured these by using questions from previously developed scales. And also we've again asked participants' willingness to get vaccinated against COVID-19. And then our main psychological predictors were conspiracy mentality. So this is a measure of a general conspiracy mentality, regardless of cultural statements that involve perhaps cultural items. So this scale has been developed to look at conspiracy mentality across cultures. And then we have also looked at people's belief in specific COVID-19 conspiracies, and then their belief in science and controlling for various other variables. So I just want to first show you the cross-cultural variation in vaccine attitudes across these 3 countries. So when we looked at general vaccine hesitancy, the kind of composite score for all these agreement with these statements, we found that people in the US and Turkey were much more hesitant about vaccinations compared to UK. But vaccine hesitancy levels didn't differ between people in the US and Turkey. And when we looked at COVID-19 vaccine acceptance, here you see, because at that time, March 2021, there were already some vaccines available in all 3 countries. We looked at people who already got vaccinated and who said they are going to get vaccinated, they're planning to get vaccinated. We saw that in the UK, again, the acceptance rates were the highest, followed by US, and the least acceptance rates were in Turkey. Interestingly, it was many more people in Turkey were hesitant. They weren't rejecting right away, but they were more hesitant. And then again, when we looked at general vaccine trust, we saw that again, people in the UK were most trusting to vaccines, and in Turkey the least. So we then conducted some regression analysis, and what we found is that the strongest predictor of vaccine hesitancy in all 3 countries were belief in COVID-19 conspiracy. So in all 3 countries, as people believed their agreement score gets higher in COVID-19 conspiracies, and they were more hesitant about vaccinations. And similarly, vaccine trust declined with increasing belief in conspiracies. What about belief in science? So this was a measure reflecting how much people think that science can explain various things in the world. And what we found is that both COVID-19 vaccine acceptance and vaccine trust increased with increasing belief in science in all countries. But then this doesn't necessarily explain cross-cultural variation, because interestingly, what we saw is that people in Turkey, many people in Turkey said that they believe in science, but their vaccine trust levels were still quite low. For example, here in this plot, you see percentage of participants who scored high on several scales. So the gray is a scale, is the belief in science scale. So you see that Americans, the percentage of participants in the States who believe in science is much lower compared to UK and Turkey, but still in Turkey, people's trust in vaccines was lower. And on the other hand, many more people in Turkey scored high on general conspiracy mentality and also COVID-19 conspiracies. So then the main question we should be asking really is then why there is this variation in belief in conspiracies across cultures. So there has been much research done on conspiracy beliefs before, but not from an evolutionary perspective. And I think outgroup mistrust may be an important predictor, because as you all know, that we are more willing to cooperate with our in-group members, and we are a lot less trustworthy to out-group members. And threats like pandemics reinforces this out-group mistrust. And conspiracies, by definition, they involve a secret group of people doing something unlawful. So now we wanted to look at whether out-group mistrust predicts the COVID-19 conspiracies, controlling for several other variables. I'm not going to go into that very much because I know we don't have much time and I want to have time for discussion. But in a nutshell, yes, our regression results showed that one of the key predictors, if not the most strongly associated predictor with COVID-19 conspiracies in all three countries, were out-group mistrust. And then finally, how can we tackle vaccine hesitancy? Well, we have been running some studies, and based on the survey that we have conducted, we have looked at some incentives that governments have been applying for increasing vaccine uptake, and we made some predictions based on cultural evolution theory, but whether prestige-based incentives or conformist incentives work better on increasing vaccine uptake of those people who are hesitant in all three countries. And you can see our results in this paper. So I will leave it here, but if you have any questions, and I've already seen some questions in the chat box about vaccine hesitancy, I'm happy to answer. Thank you.
Okay, thank you all for really fantastic presentations. Let's give a round of applause, virtual or otherwise, for those three great talks. And we do have some time left for questions and discussion. Do we have any hands up yet?
No raised hands at the moment, but I know we had some great questions in the chat.
And I've been talking with Kaylin on the chat as well, and he offered to ask his question. So why don't we get started there?
Sounds great.
Thank you. That was a very interesting set of talks that work really well together. So thank you for that. In the beginning, and it came up, I guess, a few times in different ways, there was sort of talk about future discounting, and Ruth talked about being male, low socioeconomic status, that kind of thing, and how those would be associated with a lower adherence to public health measures, or whether they be maybe social distancing or vaccination. And it seems like, it occurred to me that the pandemic itself is an extremely strong signal of extrinsic mortality, whether it be directly through the risk of COVID or maybe the economic or social sort of impacts that kind of have unfolded as a result, and especially as amplified through the media. And I'm wondering if any of you know of data, or if anyone on the call knows of data where, the future discounting behaviors, whether it's addiction or homicide or earlier pregnancies, could somehow be tied to the perceived risk of the pandemic. So almost like a pseudo experiment. And I guess that question is directed to maybe Ruth mainly, but anyone else who has thoughts on that, I'd be interested.
Ruth, you're on mute.
Sorry. I think in our paper, we did suggest that the pandemic might cause birth rates actually to go up for that reason. And I haven't done a systematic look at that. lots of people I know seem to be having babies, but the only actual data I've seen actually suggests we were completely wrong and birth rates have gone down. But I don't know if anyone, I've certainly seen data from France where it seems to have like collapsed. So I haven't done a systematic study of that, but I think I always caution about like risk as a sort of single thing. I think everyone's got very context specific costs and benefits, and so it, I don't know whether any of those very general things are going to work out, but no, I don't know the data on births, but I think we might be wrong. But having said that, we also cite a paper from Indonesia which seemed to suggest things were going the other way. So I have two anecdotes, one from France, one from Indonesia, going in opposite directions. So someone needs to do a systematic, maybe we should do a systematic review of that. So it's a great question, but the answer is I'm not quite sure. We've got examples going both ways.
And maybe those two examples might be actually reflective of what risk means in those two different contexts too. Maybe France is a very different
yeah, I mean, you can imagine that maybe in France you view it as a temporary thing that's going to be solved, by vaccines or whatever next year. Whereas maybe in Indonesia, it's just yet another thing that is going to, make life more risky.
Denise or Emily, do you have any thoughts on this?
We did a study where we looked at like effects of like future considerations, which is not necessarily the same as future discounting, but like how much a person considers future outcomes. And there are like levels of risk perception, like perceived risk of catching the virus, and anxiety levels, because my prediction was that they would be more anxious if people are always thinking about the future, especially when there's so much uncertainty. But what we found is that more than future orientation per se, it was like uncertainty intolerance that predicted anxiety. But I'm just checking the correlation metrics that we have, because you were more asking about future discounting and risk perception, right? And I'm just checking but we don't necessarily have, it doesn't seem that they were correlated, at least from the data we have. Like there wasn't a strong association between future-oriented consideration and perceived risk of catching the disease. I don't know if this answers your question, but.
Although we don't even necessarily need to rely on perceived risk, because we just know that the costs and benefits were different. I mean, we know that the costs for young people the disease costs for young people were much lower than the disease costs for old people, for example. And so it wasn't even just, we know that the disease risk in certain jobs was much higher than in other jobs. So, we don't necessarily even have to rely on perception, because we actually do know that people were just facing very different risk cost profiles.
Yeah, and I think another thing to keep in mind is, I don't know if it's to do with perception, but, how temporary the increased mortality risk is, because we know from other studies that actually if there's a temporary risk increase, people delay fertility. So they, and that was probably quite an important thing in the UK, at least, because partners weren't allowed to go into the delivery rooms, and they weren't allowed to go into any appointments. So it wasn't just the looking after children bit that women were isolated, it was also the actual, the process of pregnancy and giving birth. So I would assume, that would have been a significant incentive to delay fertility, even if you were ready to have babies or wanted to have babies, So we could see, for example, we're seeing a massive decrease in fertility in lots of different populations, but it's possible that we see a rebound in fertility, at least temporarily, and we seem to see that in other types of kind of stressful events throughout history. So I guess on the long term it's hard to know, but anyway.
Okay, thanks for the great question and the great perspective shared. We have another question from Eric Shattuck. Eric, you want to ask your question? And please raise your hand if you have a question. I would like to ask it or let us know.
Sure, thanks, Charlie. And thanks to the speakers, really, really great presentations. My question really is for all three of you, since you were all on the same paper in the EMPH, but if you were to sort of write that paper now or rewrite it, revisit the arguments that you made in that paper today, how do you think you might approach this question of vaccine misinformation, given everything that's gone on in the past year or so, particularly with people who, I suppose one interpretation, my cynical interpretation is, they're manipulating people. They're manipulating those cost-benefit analyses that people think about when they think about getting the vaccine, either by claiming that the vaccine is too risky, or it's introducing nanobots or something like that, or downplaying the costs of COVID itself. And how do you think you would approach that from that behavioral ecology perspective?
I don't know if Denise wants to say anything. She's been doing more on conspiracy theories. I mean, one thing I think I would add is I'm not sure to what extent people believe those conspiracy theories, or whether they're just identifying with a certain group as a kind of a, that those conspiracy theories become markers of a certain group identity, and that might be why they're completely resistant to actual information, because the people don't actually believe them. But that's just me putting that out there. I don't know what Denise thinks, who's been thinking about these things more than me.
Yeah, that's that element, but it also depends on the type of conspiracy, because like, for example, in Turkey, the conspiracy mentality is really high. Like on average, people really think that there are secret organizations that are like directing many important events, and believing in that, and like believing that they're gonna put like microchips. I think it's a bit different. So that's why there may be different reasons to conspiracy beliefs as well. But with COVID conspiracies, we found a strong association with outgroup mistrust. But going back to your question, I mean, it is, if like I've been thinking what more applied approaches, like what can we really do in terms of costs and benefits to individuals. One thing that we have been looking at is measuring the effects of reward-based versus like sanction-based incentives on like vaccine hesitant people's vaccination decisions. So, some countries like the States, they were making lots of like lottery, like reward-based incentives, whereas you can say that France or in Turkey, if you don't have a COVID pass, you won't be able to enter these places. Then it's more like sanction-based. But I do think that it depends again on some psychological variables. For example, we know that people who are high on reactants, there is this concept on psychological reactants. So those are the people who are very, they get really angry if someone wants to change their ideas, and they feel that it's intruding. So I think perhaps sanction-based incentives may not work well for those individuals, because it may even backfire, like you're trying to really push me to do something. But it may work well for people who are a bit hesitant, but they can like easily be convinced to get vaccinated.
It's fascinating. Sorry, Charlie. It's really fascinating to think that group membership, at least in this case, seems to be outweighing, sort of the rational cost-benefit analysis related to the pandemic.
We're almost at the top of the hour here, and we do try to end within an hour. I wanted to sneak in one last question, if I could. I wanted to ask Emily a question about the interesting results that she presented. Just two quick kind of clarifying, well, one clarifying question, one general question. Were these, I know you mentioned that it was like about 50% of these mothers were firstborn, or it was their first child. Was there an effect of whether it's the first or second, and maybe I just missed it, or first or non-first in terms of the depression, postnatal depression?
I can't remember if I'm honest, but what I do remember is that at least in the qualitative responses that we analysed, mums with multiple children had a terrible time. So you know, which I think I don't know if that actually came out in the models, particularly because we had a relatively small sample, and you know, the variation in terms of number of children and things like that is not particularly high in our sample, unsurprisingly. But at least in the qualitative analysis, that was something that came out really relatively strongly, which is that if you had multiple children and there's no childcare and you're trying to look after a newborn plus toddler at the same time, I think it was a disaster, really. So.
I'm also curious if there are any equivalent studies like yours that have looked at women who are unable to connect into their kind of, you know, physically in-person connect into their social networks after birth. You know, for example, after moving overseas, or maybe there's some kind of health issue, and how does that impact does it have the similar impact on rates of postnatal depression?
So we know, in terms of like predictors of postnatal depression, we already know that social support is a significant determinant of postnatal depression. So it's really unsurprising, I think, in a way, our results. This is what we would expect. I think what I was particularly surprised about was the level of postnatal depression that we identified in our sample of women who are often associated with lower levels of postnatal depression, because they, you know, our sample was a little bit wealthier, they all had partners, you know. So what I would suspect, and just to say also, we've been collecting, so this was what we presented was just London, but we've been collecting nationwide data, longitudinal data now, and we've kind of replicated the postnatal depression levels across the country, so it seems to be a widespread effect. I would probably think that postnatal depression levels may have been even higher if we had like a more representative sample, although you don't know the level of compliance, I guess, with social distancing. So we had really high compliance levels in terms of mums not seeing anyone. So it could be that actually if the cost of social distancing was higher in other groups, then compliance might be lower, and that could impact PND, I guess. But it wasn't great. That's what I'd say.
Okay, thank you very much. Thank you all for fantastic talks. That was really great to hear the kind of follow-ups that came from this paper in EMPH, and to have a refresher on that and your perspectives on that, Ruth. So thank you very much, Ruth, Denise, Emily. Really appreciate your participation today. Thanks very much. Thanks for everyone for coming, and for Meredith for all the work running these. And I'll just quickly share our upcoming, I'll share the screen here of our website and the upcoming Club EvMeds. Here's the great talk we heard today. We have another Club EvMed next week on Thursday at 1 o'clock Eastern time, so 2 hours later than today. We have Samuel Pavard and Christophe Coste speaking about a really interesting paper that they recently published. So please check out this paper and tune in. Looks to be a really great conversation. And you can see the other events that we have coming up over the course of this semester, at least 3 more that are already lined up. Okay, so again, thank you everyone, and hope to see you next week.